So many trials are showing the advantage of surgery over PCI long term, and yet it's just not fun getting your chest cracked open. So are there alternatives? Well, now science seems to be looking towards hybrid coronary revascularization for the treatment of coronary artery disease. We're talking about a multi-center observational study, and we're with Dr. John Puskas, who is Professor of Surgery and Associate Chief of Cardiothoracic Surgery at Emory. I think it's an exciting time, technologically speaking, correct?
It's a fantastic time technologically. I would tell you I think it's a great time culturally. The culture of the cardiac team, the heart team approach, is new and it's growing, it's really taking hold, and this empowers and allows really collaborative new ways of taking care of patients.
I mean, we've always had teams, but there does seem to be more of an emphasis on it in today's world. There has to be.
And I think, frankly, it's multifactorial. It's been driven by payers, by the government, and also by our experience with the TAVI. With transcatheter aortic valve replacement, that has been necessarily a team approach, and it's been enormously successful.
So in this particular presentation that you're making at ACC 13, what are you talking about?
I'm talking about, on behalf of the other investigators of the NHLBI-sponsored observational hybrid study, talking about hybrid coronary revascularization as a therapy for patients who have a particular pattern of coronary artery disease that includes a proximal LAD lesion and a lesion elsewhere in the coronary system. So this therapy combines, we hope, the advantages of surgery in terms of long-term durability and longevity provided by an IMA graft to the LAD, with a less invasive approach, where we, instead of using vein grafts to the non-LAD vessels, we are in essence replacing those vein grafts with drug-eluting stents. And this is a minimally invasive surgical approach done typically robotically with 3 10-millimeter incisions under the left axilla and perhaps 1 4-centimeter incision medial to the left nipple. There's no bone division, no sternal split, minimal risk of bleeding, minimal discomfort, early return to work, and a very high patency rate of that internal mammary graft to the LAD.
In terms of the technology, where are we? Is this something that doctors need to start paying attention to, or are we still a few years out before it gets more widespread?
Well, we are in an early adopter phase with respect to the surgical side of this. Our PCI colleagues are, ubiquitous and skilled in taking care of a mid-right or a mid-circumflex lesion that may come along with a proximal or ostial LAD lesion. But the number of surgeons who are able to do reproducibly precise robotic or truly minimally invasive grafting of the LAD is small but growing. And nationwide we're seeing this pick up steam.
Outside of the heart, this has actually become more common for a variety of techniques.
Well, laparoscopic surgery has essentially replaced open laparotomy in essentially every center in North America and in Western Europe and much of Asia. Using truly thoracoscopic approaches to treat cardiac disease is relatively newer and more limited in scope, but again growing and being applied for hybrid therapies of atrial fibrillation, to manage the left atrial appendage, for robotic bypass of the LAD, and a very few centers doing more complete revascularization of multi-vessel disease via either no incision with a robot or very minimal incisions.
I talked about the fact that it does appear that the data keeps showing that the bypass has some real advantages. Do you think this is going to help drive the technology?
Well, this, I think, is a win-win situation for the patient and actually for the providers, much the way TAVI is.
We're trying to reduce radiation.
We're trying to reduce radiation, that's true. The hybrid approach does not, in fact, reduce the role of the cardiologist. In fact, it amplifies it. This is a team approach. Rather than a patient coming to the cath lab, discovering ostial LAD lesion and a mid-right lesion and having an easy, high reliability stent to the right and a less easy, less reliable stent to the ostial LAD, that patient may have, instead a robotic bypass to the LAD and a stent to the right. We like to do it in a pattern that's sequenced so that we will do the robotic bypass first, then either have our cardiology colleagues come into the hybrid suite, cath the graft, demonstrate the patency of the IMA, and then stent the right or the circumflex. Or occasionally we'll do the hybrid revascularization in a staged approach with the surgery first and the cath the next day and home the day after. Either way, it's a necessary partnership. There's a diagnostic procedure, a diagnostic angiogram, and a subsequent therapeutic angiogram involving a drug-eluting stent and documentation of the IMA quality.
So few one-man bands today.
This is
It's
not
an orchestra.
This is an orchestra. It's at least a chamber orchestra. It's a small, highly skilled group of people doing a performance together.
And you can read a lot more about this and other topics from ACC 13 and CardioSource World News. I'm Executive Editor Rick McGuire.